meeting is now being recorded.
The INCOSE Healthcare Working Group is one of several industry-focused working groups within INCOSE. Healthcare and biomedical applications are still a non-traditional industry for systems engineering, so the Healthcare Working Group was formed to bring together systems engineering practitioners and systems thinkers in order to share experiences and improve the overall state of systems engineering for healthcare and biomedical applications. We also are very interested in working with systems engineers from outside healthcare so that we can learn about the tools and techniques from the traditional systems engineering fields like defense, aerospace, and automotive, and gain experience in applying knowledge from those fields to the problems in healthcare. The Healthcare Working Group has a number of work streams pursuing various aspects of systems problems in the healthcare industry. We welcome all of you to contact one of the working group POCs in order to obtain more information, and we always welcome new participants in our technical efforts. Drop me a note at the email address shown. I'd be happy to send you a short overview of our group and our activities. Each month I like to highlight some of the recent and upcoming events for INCOSE and the Healthcare Working Group. As I mentioned in our last webinar, the Healthcare Working Group's annual Healthcare Systems Engineering Conference was held last week in Minneapolis. The theme was, How Can Systems Engineering Reduce Cost and Improve Quality? We had excellent tracks on cybersecurity for medical devices, agile hardware development for medical devices, reporting on control loop models as part of FDA submissions, as well as a broad range of submitted talks. The presentations will be available to attendees very shortly, and they will be available to all INCOSE members via the INCOSE Connect website in a few weeks. The next major event on the horizon is the annual INCOSE International Symposium. This year, the symposium will be held in Washington, D.C. from July 7 to 12. As always, the symposium will begin with 2 days of tutorial offerings covering a range of basic and advanced systems engineering topics. This will be followed by 4 days of plenary sessions and technical presentations. This year, there will be a 1-day track addressing healthcare topics. You can see in the view graph a few of the subjects that will be presented. The complete program can be found at the website www.incose.org/SYMP18/home. Registration for the symposium is already open. I also want to give you a quick heads up about our May webinar. Our May speaker will be Richard Beasley, who is an Associate Fellow of Systems Engineering at Rolls-Royce PLC. Richard will be presenting an overview of the UK Royal Academy of Engineering study called Engineering Better Care. This study was performed jointly with the Royal Academy of Physicians, and Richard was part of the INCOSE UK team that was invited to participate while systems engineering methods could benefit the UK's national health system. The webinar will be held on May 25th at 11 a.m. Eastern Time. Note that this is 1 hour earlier than normal in order to accommodate the time difference between the United States and the UK. Webinar details will be emailed and posted to our LinkedIn site about 3 weeks in advance of the webinar. I'd like to quickly review our SOP for the webinar. We'll have roughly 45 minutes of presentation, followed by Q&A. Your phone lines will be on mute during the presentation, so as questions occur to you, please type them into the chat box in the lower left of the Global Meet screen. At the end of the presentation, we'll address the chat box questions in the order they were presented. Due to issues we've had with background noise and feedback, we will keep everyone on mute and will continue to accept questions through the chat box. So as the Q&A discussion proceeds, please continue to enter your questions into the chat box, and we'll get to as many of them as time allows. Please note that the webinar is being recorded. The recording will be stored in the members-only area of INCOSE Connect. It may take a few days for the recording to get posted. Now I would like to introduce our speaker, Kevin Gunn. Today, Kevin will discuss with us his team's investigation into the utility of automated detection algorithms to conduct continuous observation of healthcare information technology systems, indicators of risk to patient safety caused by the healthcare IT. Kevin will discuss the conceptual architecture his team has developed as the basis for future design and implementation of a healthcare IT auto-surveillance solution. He will also discuss the proofs of concept work performed for the Veterans Health Administration in 2017. Kevin is a systems engineering professional and leader skilled in interdisciplinary communication, collaboration, and team building. As a systems engineering principal at the MITRE Corporation, Kevin directs projects in a broad range of business areas. Most recently, he has served as the project lead for several projects supporting the Veterans Health Administration. Mr. Gunn received his BS in computer engineering in 1995 from Clemson University and an MS in management of technology in 1998 from the Sloan School of Management at Massachusetts Institute of Technology. Kevin, welcome to our webinar, and thank you for being willing to share your work and your innovative ideas. If you'll give me just a minute, I will stop sharing here. And now you can begin sharing and give your presentation.
Right, and can everybody hear me okay, or can you hear me okay, Bob?
Yes, yes. You're coming through loud and clear.
Good. And are you seeing my screen?
Yes, I am. I can see the title slide.
All right, good, thanks. So, hi, folks. Again, Kevin Gunn, and Bob did a kind of a glowing introduction, so I'm not worthy of that. But I just want to introduce this. First, I'll introduce the problem. A bit of a caveat. This is work that we did with VA. It's not publicly releasable, so I won't be sharing the slides. And what I'll really be doing in the slides, it'll be sort of an overview, and then I'm going to go into Visio and walk through the conceptual architecture, or at least one view of the conceptual architecture that we did for VA. And this was back, now it's been 2 projects ago for me. So we wrapped this up in the fall, like in October or so last year. So if I could get my slides super advanced, here we go. So the idea here, and Bob touched on it, HIT systems, they provide a lot of benefits, obviously, and if we work with HIT systems, you know that. So there's a lot of automation of things like prescriptions and order tracking and medications, and so it's streamlining communication. So it has a lot of benefits, but there's also potential for the health IT to actually introduce issues and introduce threats to patient safety. The systems may fail in some unexpected way. There's complacency and sort of the alert fatigue that information might not get entered. Surprises with the automation. Your workflow may not actually match what the HIT is trying to walk you through, so you may take shortcuts or miss things. And with the multiple systems that we're using and information being shared, or at least even within modules within one big system, like think Epic or VA, it's Vista, there may be some errors that may propagate and go undetected. So the idea here is that because they can introduce these kinds of errors and threats to patient safety and even quality of care, that current techniques that they use to detect these things or react to these things is reactive, right? So it's some incident happens, some harm comes to a patient or almost comes to a patient, and they go back and they have to say, okay, why did this happen? And they look back and say, oh, well, yeah, here's, this provider did not enter the right date here, and that, propagated and it caused this threat or actual harm to the patient. Right now, there's no electronic detection methods built in. There's a little bit of error checking, make sure you fill in this field, that kind of thing, but it's not done with a sort of this holistic patient safety umbrella over it. And the idea is we want to be able to surveil the health IT and the data within the health IT, and the hypothesis is here that we can electronically monitor the health IT systems and detect hazards to patient safety and quality of care in more of a real time. And the hope is to be able to intervene before harm actually comes to the patient. So our goal here was to inform the development of it's very vague, right? So it's very forward-looking. So inform the development of a prospective approach for auto surveillance. So this is a new concept. Nobody does this. And we had, as a team, we came up with an architecture and a set of methods and a set of algorithms to use, and we built a proof of concept. But we wanted to be able to identify hazards to patient safety that would be introduced by health IT systems. We worked with providers to figure out what is sort of the most common ones or the most dangerous ones. So we kind of prioritized, and we picked a couple at the top to do a proof of concept on. We wanted to build some generalizable methods for detection and communication of the hazards. So it couldn't be overly specific, although the architecture is not, but the proof of concept is kind of specific just to show that the concept works. And then we want to create a framework for guiding the methods of detection and remedies of the hazards, understanding the classes of health IT-related hazards that are conducive to surveillance, some are not. And then this conceptual architecture that I'll present, and this is a solid system engineering application within the healthcare here. So this is kind of hard to see, but this particular screen, but the idea here is this is a timeline, right? So some hazard precursor, there's maybe some feature in the system that was built wrong, or some circumstance that might be detectable is introduced at some point. Or there's a precursor to it that could be detected to prevent the hazard from being introduced. So you're in a stage here of preventative detection and mitigation. So you could be looking for these things, and you have some opportunity to prevent that hazard. Then you get to a point where a hazard might be introduced, where a data field is entered incorrectly, or they don't hit that last OK that actually sends the order, that kind of thing. And that, in theory, can also be detected. So we have this opportunity to detect this thing. So at some point in time, we detect it. And this is where we get into a proactive time frame here in the timeline, where hazard's introduced, at some point we can detect it. And the idea here is we have an opportunity here to mitigate that hazard. So it's introduced, we detect it, and now we're going to try to do something to mitigate the hazard. It just depends on what the hazard is. So if it's, we'll use that example of hitting OK on an order. The order doesn't actually go through to for instance, the pharmacy, and that could introduce a threat to the patient's safety, especially if it's a critical medication that the patient needs. Once we detect that, oh wait, they didn't hit OK, we were looking maybe at a workflow in the data, and we see that it stopped at some point, we can at least flag that as, hey, this order did not go through, which may be a feature that's not actually built into the system. So we have to, because the system might be assuming you'll hit OK when it's OK. If that hazard is detected, we have an opportunity to mitigate that hazard before the care process is compromised. And when we say the care process is compromised, that means that, okay, they didn't get the order, the patient did not get the medication. Once that happens, we can detect that at some point. So we have this opportunity of detecting it. Now we're getting into more of the reactive, because now the care process has been compromised. We have an opportunity, once we detect that the care process has been compromised, the doctor goes to the pharmacy and say, hey, where's that medication? And they say, well, we never got the order. So that's a compromise in the care process. And then patient harm could eventually occur. They don't get the medication in time, and there could be harm from that. So there's that harm that happens, and you have an opportunity here to detect that harm. And once you detect it, hopefully you'll do something about it. But at that point, you can't mitigate it or fix it. The harm has happened, and now you get into the phase of what they currently do on the far right side. The current practice is the harm happens or almost happens, and they look back and see, well, what's the root cause of that? And this focus for the auto surveillance is early on in this timeline. You see at the top here that we're looking at when a hazard is introduced and being able to detect it before some care process compromise happens. We don't get into the mitigation piece because that's more of a clinical decision on how they would want to do that. But at least we can present that, hey, here's this hazard. Now somebody's got to go figure out what to do about that. And we'll talk about that in the architecture. We'll skip over. Well, the idea here is you have a bunch of indicators that exist within the system that you can look for. You've built some detectors that can find those indicators. So it's something in the data that you're looking for specifically. And that provides some evidence of a potential hazard. And you have some different classes of hazards. On the far left is, in the yellow here, is the things that are related to the safety of health IT. So these are technology-induced hazards. So mismatches in medical codes, data loss, patient record mismatches. So these are all attributable to the technology itself. On the far right, we have far right of the spectrum is the safe use of health IT, the blue box. And this is the data entry errors and completing a task properly that we talked about, unsafe workarounds. And then in the middle, we have sort of this combination, of course. It's always a hybrid, right? So there's a technology-induced human HIT error. So this is poor design. There's not, coordination is not happening within the system, maybe some awkward user interfaces. So these are things technology and the user combined introduces hazards. So these are the kinds of things that we're trying to look for with auto surveillance. So what we did was we came up first with a view that shows, okay, what are all the relationships and the information flows within the system, and introducing the idea of auto surveillance and how can we impact this. So I'm going to build this out slowly. So, of course, at the top we have the patients. They provide information to the user, which could be a clinician or a non-clinician. They interact with them. The provider provides care to the patient. They may get some data from their electronic health record, which we have the health IT platforms that the HIT users use. The patient may provide data to the health IT platform. So we have all this interaction going on up here as your typical, this is your generic healthcare provision environment, and the use of the health IT. So it shows these interactions. And the health IT actually exists on some health IT networks. And pardon me, this is a little kludgy the way Visio does this, so I'll have to do this slowly. That health IT network, health IT platforms sit on the health IT network, and they produce data of different kinds. So this is sort of a spectrum of from left to right, it's sort of the increasing age of the data, and from right to left, it's the increasing difficulty to access it. So during the use of the health IT, and it could be tablets and PCs, servers, whatever platforms they're going to exist on some network. There may actually be some data that's embedded in there that may be directly collected. But you have on the far left here the stuff that's immediate and immediately detectable, but very difficult to access is keyboard, key presses and mouse clicks, and mouse overs, those kind of events. And then moving to the right, where it's maybe a microsecond later, but there's network traffic that you could detect. So that's another source of data. There's transactional data. So that's the actual screen that's sent, or the OK button, that kind of thing. Then you get into things like message queue and files, and again, these are all a little later in the stream, and they become increasingly easy to access. When you finally on the far right, you get to this idea of data warehouses, and that's something you can access, but it's typically dated, so maybe a day old. And that might be too late for our purposes, but it's certainly the easiest thing to access. So going the next layer down, multiple mouse clicks, user interface design problem. The idea here is that we have all this data available to us. We want to be able to translate this data into something that we can do detection against, right? So you have all these databases probably have different schemas, different ways of accessing them, but a lot of the same information is going across them. It just looks different as you move up the spectrum, right? A keyboard click is just, it's an interrupt or something that you can detect. but as you get, up the chain, that series of keyboard clicks or mouse clicks becomes some other information, and it changes, the nature of the information changes, the shape or the schema, if you will, of the format of the information changes as you move up. So what we want to do is be able to translate, no matter what we're looking for, we want to be able to, and whatever EHR we're looking at, we want to be able to translate that into some standard surveillance data formats. So there's this translation function that produces these hazard-focused data models. And there's two types of those sets of data, and they're structured differently, and different hazards are detected differently depending on the type of data. So there's this idea of event data. So this is event stream data. It's a series of events that you're capturing, and you're looking for some interruption or something happening in that series of events that you're recording. And again, it can come from any one of these data sources or a set of these data sources. Again, we started with the warehouse end, and we'd like, the idea is to move back to the left to catch things earlier. And then we have this idea of slowly changing data. And this is where we have like snapshots of electronic health record. And so these are things that are that change more slowly, and even orders, things like that. That wasn't orders in. That's probably not going to change a lot. So we have this think data warehouse, right? So we have big chunks of data that change very slowly, but we want to have that in a format, a standard format that we can build detectors against. And we talked about, in our report, we talked about things, the different standards we might want to look at to help shape that slowly changing data. So the next layer down, so now we have the data from the EHR, we've kind of separated it, extracted it from the electronic health or the health IT into a new data format that we can now build detectors against to find these hazards. And this should be essentially a more real-time kind of activity. So we have this data. We want to build, we have a concept here of a detection dispatcher. So we have some logic here that defines what the hazard indicators are, what you're going to be looking for. Some hazard detection algorithms, if you're looking for something, a series of events or some combination of things. And then there's this idea of an aggregate hazard detection, which is looking at perhaps a time series of events, or you're looking at several different things, like a prescription and administration and an order. And so several things that are across the spectrum that together might indicate the hazard. So that's sort of the overall concept of hazard detection. So there's this idea of control. You have these detectors that you're going to query in response this hazard-focused data model. There's also some control going on of what kind of data do we need to pull, because the idea here is that you're evolving these detectors over time as you learn. You're building new detectors, new hazards are discovered, or you're working down your list of priorities. You want to pull the minimum amount of data that you need to do your detection. So there's this idea of control of, we're only going to pull the data that we need to satisfy the detectors that we have currently. So this detection dispatcher is doing this query and response and providing the indicator data back to the hazard detection modules here. And depending on what the hazard is, defines what is done with it. So we have a few other databases up here. There's this concept of hazard models. There's some AI models that we applied to some of this. And so we have this sort of repository of hazard models. There's a repository of the detected indicators. So hazard indicators are detected and recorded. You may want to access those to do the aggregate hazard detection if you're looking for multiple indicators that together represent a hazard. And then combining all those indicators may produce a hazard. So if you think an indicator by itself is it's one data point. That one data point could represent a hazard in itself. Generally, it's going to be some combination or some series of things that you're looking for, those indicators that you're looking for to detect a hazard. Or it's some combination of those indicators of that indicator with some other indicators that you aggregate to detect a hazard. So you store your indicators and you're using that as in your logic, once you detect a hazard, you can identify that, and there'll be a repository for the detected hazards. So, and all of these databases here represent a data model that we had to create. That doesn't exist, and there's no standards for them. But the idea is we wanted to create these data models to separate the HIT from the auto surveillance. So it provides that layer in between that makes the hazard detection independent of the particular solution of your health IT. And let's see, next layer.
Before you go on to the next layer, let me interject a question from our audience here.
Yes, sir.
You were talking about using AI as part of your hazard model. Have you looked at how that process will occur? I mean, AI means a lot of things to different people. I was just wondering if you had any further thoughts on that.
Yeah, so they used. I'm not the expert on this, but with the proof of concept, I know they used some neural network techniques to look at time series data, and again, we started with data on the data warehouse, and they used some algorithms to look at this data and build a time series of events and look for trends, I guess, or look for indicators in that using these neural network techniques. I don't know if that makes sense.
Okay, that makes a lot of sense, going back through the historical data and having, I would assume, you'd be having a lot of clinician input at that point on, that turned out to be something.
We interacted a lot with the clinicians at VA. We got a few that were sort of
great.
For us.
Thank you.
Sure, thank you. I almost missed this other source of data up here. So, this comes in with the users. All right, so let's talk about the users. So, of course, we're going to have a human in the loop, right? So we're at this auto detection, but you don't want to do anything with that. Well, you may not want to do anything with that information in an automated way because there may be some decision that has to be made or some prioritization that has to happen. So we introduced this concept of the human in the loop. We have this set of surveillance activities. So we have what we call a surveillance user, and this is the person that's sort of monitoring the dashboard of hazards and indicators that are being detected, and they may be controlling those as well and saying, okay, well, let's pull this information. They may be getting raw data, or they will be getting raw data directly from the health IT. It's not translated because they may want to use that to do some non-automated or apply some analysis to. So we have these surveillance users, we have these analysts. Through the surveillance user looking at the dashboard, the analyst doing their analysis of the data that's being collected, they may detect, and they're getting the hazards here. They may detect something through their analysis that was not auto-detected, perhaps because we don't have that algorithm built into it yet. So they would want to flag that as hey, we detected another hazard. Let's add that to the hazard repository. And again, all the hazards being pushed through here. There's also unstructured data that might inform this. So there's things like trouble tickets, user feedback, focus group surveys, reports, other studies that have been done, perhaps social data, all of that may be coming from other external sources, such like academia, first responders, health IT vendors, even the patients and the clinicians with user feedback and focus groups. So this is all sort of unstructured information, we called it, of this nature here, that it's going to be things that they can use, the surveillance user, and especially the analyst can use as another data source to match up against what they're actually seeing and perhaps focus on what they're looking at. So we wanted to make sure that was included. Even though it's not part of the automated solution, it impacts the human in the loop. Next layer. It's popping up on another screen for me. That's why you're not seeing anything there. Now we're looking at, the hazard models. So through this analysis, you may be detecting new kinds of hazards or new ways of detecting hazards by doing this analysis. of the raw data, of the hazards, of the unstructured information that you're getting. So we have this concept of that you're going to be developing new hazard models because we might be discovering new hazards. So those hazard models then would get deposited in our hazard model repository, and if it's going to be used, it'll be available to the hazard detection function. But we also introduced this concept of an external collaboration. So we would share our hazard model because we have this sort of standard that we're developing and the data models that we're developing. We'll have the ability to share that open source. And the idea is that we would build up an auto surveillance community that's developing new detectors, providing feedback or sharing lessons learned about auto detection or about mitigating hazards that are detected. So there's this, the idea of a network of expertise, not just completely internal development. So we want to make sure we introduce that concept as well. And it affected the architecture. We had that they're going to be building new models. They're going to also be interacting and bringing in new models. They may bring in a new model from the community and just dump that right into the hazard model repository because it's good and it works. But they would do the testing and that sort of thing. So that's the community aspect. Now we get into the idea of mitigation. Again, our scope did not include defining the mitigation, but what we did say was if you detect a hazard either through analysis or automated or through surveillance or even the set of indicators, there's this sort of spectrum of responses that you might have. So there might be this real-time or near real-time response. This is likely when you're using data on this end of the spectrum, the keyboard, network, even transactional data, stuff that you could immediately respond with or mitigate just by popping up an alert or by auto-correcting something. And so this may be something that's not currently built into the system, may eventually be built into the system, but the idea here is on this left end of the spectrum is the stuff that you can reply to immediately. On the far end, there's your responses are more there may be some clinical action you need to take to mitigate the hazard. So it may not necessarily be something you can do in real time. It's something you're finding late in that timeline, that kind of thing. So there's different levels, and this actually on this far right may actually be, making changes to the auto detection software because you might change some detectors or change some hazard models. So there's this sort of long-term response over here on the far right. Regardless, we're still in this. We still have this lessons learned that we're sharing with the auto surveillance community. So as we mitigate things, we also review, well, how did it go? How did it work? And so we'll be collecting those lessons learned and sharing them and learning from what the community is doing. And we also, the mitigation, we want to make sure this, most mitigation is not going to be automated, right? So we may have some automated real-time kinds of things here, error correction, alerts, and that's fine. But most of the kind of mitigations that you might have as far as clinical interventions and system changes or trouble, responding to trouble tickets, there's going to be another human in the loop that would actually perform that mitigation. So we have this other set of actors over here that are performing the mitigation actions. And let's see, we're getting close to the last layer here. Let's see. Okay, so no, that's there. So that's the overall concept. We did do another one that was more technically deep, but with this one we wanted to make sure that we define some of the key pieces in here. Is this concept of having a separate hazard-focused data model to decouple the hazard detection algorithms and models from the actual implementation of the health IT. And the detection dispatcher, that concept is a way of controlling what data you're actually pulling, so you're only pulling what you need. Your detectors will define how timely the data needs to be, depending on what kind of detectors you have, hazard indicator detectors you're building. So you're only pulling that data that you need at the rate that you need it. So there's this idea of how frequently are you pinging this data, and you have to balance all that. So what we wanted to capture in this conceptual architecture was, the various components that both decouple the detection from the health IT, but also involve the mitigation and involving external actors, external information, unstructured information, this idea of a community of auto surveillance practitioners or developers. So this is not in a vacuum. This is not strictly for VA. VA wants this to be something that could be implemented widely, anywhere, really. Our hope was to build an architecture here that would enable that community and enable the ability to use this in any environment, any electronic health record environment. So all you have to do, well, not all you have to do, but the thing you have to do, depending on your particular health IT, is to customize the surveillance data translation to convert this data up here into the event data and slowly changing data that you need for the hazard-focused data model. Okay, were there any questions, other questions here that popped up?
A couple things occurred to me. When you start looking through the data, trying to identify indicators or hazards, I mean, the example you gave of, okay, an order gets entered, but the final little step doesn't happen, and so there's a delay. I mean, that's kind of a protocol type of error, but you also have, errors where, okay, we've dug through the data, we've indicated that, somebody who's been, treated in a certain way, they need to have certain follow-up treatments. Those treatments haven't occurred, and it might be a more medically oriented type problem that's showing up. Do you see your system detecting both of those, or just focusing on things that are embedded in, IT operations?
I'm sorry, repeat the second one again.
The second one would be looking at the physiological data on the patient and saying, okay, here's a medical issue. Somebody ought to look at this and think about it if they haven't already. Right.
Okay. So that could be part of it, but typically that's going to be, when you're looking at that kind of data, you're looking further down the timeline, where there's potential that the hazard already happened. Now, an example, I think, part of the logic could be, and we didn't do this in the proof of concept, but a particular detector could be looking at event data, and maybe so it's going to be an aggregate detection. So it's looking at this event data and it sees indicators of, okay, that submit button wasn't clicked. And that, in combination with, we have a set of diagnoses or interventions in the electronic health record for the patient that indicate that that particular medication is critical for that patient. And if they don't get that medication within a certain time period, that's going to cause harm to the patient. And so we have that logic built in as well. So that, along with the event data for that particular patient, that would flag a hazard. And so it could be something probably real time, but it could be an automated hazard. And the response to that could be, the mitigation to that could be an alert or a notification or email sent to the clinician. So there could be, but it would be something that would be, it could be automated. It could be more real time.
Okay, so we're really focused on, or your project is really focused on, just the IT system and how it functions and what it's supposed to do, and the issues of, the whatever it is, the hundreds of thousands of deaths a year that happen due to preventable errors during medical treatment. That's not really your focus right now. There's, I'm sure, out in the future maybe some potential, but you're not trying to track down here's an error that was made by a physician that should be different. They should have treated things differently.
We kind of started with that. We started with sort of a laundry list of what are all those common things that have happened in the past that caused harm to a patient, or almost caused harm to a patient. And with the clinicians that we were working with, we kind of went through and prioritized those and sort of clarified them. Because some of them we came up with, like, that happens, but it's not very likely. So let's drop down that. We're not going to really dig into that one. But then others kind of rose to the top. And forgive me, it's been a few months since I worked this, and I don't remember exactly which ones we rose to the top. I'd have to dig that up. But so that was sort of the method we used was what are those hazards that are introduced by the health IT, or the use, misuse, or non-use. It was the phrase we were using of the health IT. And the non-use involves things like workarounds, which can be detected in the data. If you think about an event stream where you expect a certain workflow, and you see steps A, B, and C are done, and then nothing for a little while, and then F and G and H are done. So you've missed, D and E. What happened to those? And is that going to introduce a hazard? So you may have workflows like that if something that's typically automated doesn't happen and the workflow continues further down the line in your event stream or your time series, then that could indicate a hazard. So that's where you really get into the clinical workflows and the expertise of, well, how bad could that be, and that kind of thing. So those are the kind of conversations we had with our clinicians.
Okay, yeah, that certainly sounds like a lot of work to be done there in terms of trying to understand those clinical workflows and which ones are going to leave a trail in the IT system and which ones won't.
Right.
There's a question here about what about the Hawthorne effect on people being surveilled? Now, I certainly am not familiar with the Hawthorne effect.
Can you unmute Raj?
Okay, I will go ahead and do that. Raj, I'm going to unmute you for a second here so you can explain that question. Okay, can you talk now, Raj? Okay, I guess we're having a little bit of a challenge connecting with Raj. Raj, if there's anything a little more that you can put into the chat box, that would be great. If anyone else has questions they'd like to ask, please put them into the chat box here over on the lower left.
Yeah, Raj had another one here, it looks like. How does auto surveillance affect the number of medical mistake-related events?
Yeah, we were chatting about that one earlier in terms of what data you were looking for, and were you searching mostly for things generated by the IT or things generated by any other cause, the kind of big data problems that people are hoping to address?
Yeah, I think in general we're looking at those things again that use, misuse, or non-use of health IT. So we're focused on those things. Because there's plenty of other things that might introduce harm.
So is this primarily oriented towards, a hospital environment where you have things going on in real time, or would it apply to, a longer term thing where as people are doing a whole series of outpatient kinds of things, the physician is entering stuff into the medical record, the patient may or may not be entering stuff. Would it?
Right, and that actually is one of the scenarios. That's one of the scenarios that we focused on was the because VA has this the whole thing with scheduling and the VA Choice Act and using external providers, all that stuff. So one of the scenarios we looked at was the referrals and the lack of data that they get back. That they may not get back the report from the specialist, the external specialist that they sent the patient to. So that was one of the scenarios we looked at, and can we detect that? Because there's sort of an electronic disconnect when you send a referral out or a consult out, and the specialist, the external specialist, may or may not provide the care. Maybe they don't get the order. Maybe they can't schedule it. Maybe they decide not to see the patient, or the patient doesn't show up. So in getting that data back, so those are the kinds of things that we'd be looking at. And again, it's, like you said, a longer-term thing. And it could be sort of a time series look, or just looking at the EHR and saying, well, wait a minute, here was this order written for a consult, but we never got any results or follow-up appointments or anything related to this consult, and it's been 120 days or whatever the threshold you define is. So those are things you're going to be looking at, a longer chunk of data. And depending on time frame.
No, I mean that would again another large chunk of workflows that need to be captured and build up over time. I'm not sure if you can see the chat box. We did get some feedback.
Oh, I see. Okay.
On the Hawthorne effect of people changing their behavior because they know they're being watched and they're somehow doing something differently because they know they're being monitored.
Well, I think so technically we're not watching people, we're looking at data. And this typically would be transparent to the user. So I don't think they would even know that we were looking for these things. But then, it would probably largely show up as this is a great new feature. It's actually alerting me that this didn't happen and it needs to happen. I would think the Hawthorne effect in this case would be, more awareness of the potential of this particular hazard that, I didn't hit okay. I got a really, I got an alert about that, or I got, a notification about that. I'm going to be more careful in the future to make sure that I'm hitting okay. Does that make sense? So I would think it would be a positive thing.
Yeah, hopefully it would be a feedback on what the standard procedures are. I mean, there are some of the things where there's a whole series of steps and checks and authorizations that have to happen, and the nurse that's attending the patient is responsible for multiple patients, and so gets something started, comes back, sees it hasn't gotten to fruition, and then is wondering, well, how come that didn't work? If she could then get feedback that says, oh, well, it's hung up over in the pharmacy waiting for somebody to do something there, or it's, hung up here because you didn't get somebody else to check your work and put their authorization in. I would think it would provide positive feedback.
Right. Raj had another question here about has the system had an effect on preventable hazards in health IT? This was a conceptual architecture, a proof of concept. Again, nobody does this today, so it hasn't been tried in a clinical environment. So we're still at the concept phase with this.
Okay, we have just a couple more minutes. Are there any other questions out there? Okay, I think we'll wrap up for today. Kevin, thank you very much for making the time to give the presentation. I certainly enjoyed it, and I hope everyone else on our audience did as well. So if you'll stop sharing, and then I'll stop the recording, we'll be done.